my name is Mustafa Azad, and this is a brief reminder of our interesting case that was presented in the previous episode. 21 years old female was presented with right XT 50 prism diopters and hypotropia 50 prism diopters and limited elevation of both adduction and abduction after falling from height and right unknown ocular surgery when she was 4 years old. Orbital imaging was normal. In the first step, right forced adduction test was mild positive for the inferior rectus. Exploration of the right vertical recti showed anatomically normal superior rectus, but the inferior rectus was thin fibrotic with irregular borders. I decided to do left lateral rectus recession and medial rectus resection to correct the exotropia, and right inferior rectus recession 8 millimeters. After 4 months, the patient was exotropic 4 prism diopters with right hypotropia 30 prism diopters, and the elevation improved slightly in abduction. In the second step, I did superior transposition of the lateral rectus in the right eye. 3 months after the second surgery, the patient became ortho in primary position with marked improvement of elevation. Thank you.
Hi, I'm Dr. Ahmed Taha. I'm honored to participate in such an interesting event, and thanks for inviting me to comment on such an interesting, well-presented case. Monocular elevation deficit syndrome. It's mostly congenital and mostly with tight inferior rectus with variable degrees of elevator weakness. It presents with hypotropia in primary position, ptosis, limited elevation across the board, and chin elevation. Conventionally, treatment is with inferior rectus recession and NAP procedure. However, this treatment is full of challenges. Regarding inferior rectus recession, improper dissection as a tight muscle is more fragile than it looks, which greatly affects the lower lid position, producing lower lid retraction, which could be treated by putting a spacer. Incompetence in down gaze due to large recession in large angles, which could be treated by doing a contralateral inferior rectus recession or FADN. Pattern changes due to weakness of down gaze adductor, which could be prevented by doing a nasal shift during recession. Regarding NAP procedure, anterior segment ischemia, which could be prevented by spacing the surgery, partial tendon NAP, or single horizontal muscle transposition. Horizontal misalignment, which could be prevented by following the spiral of Thilot during transposition. Regarding this case, I have further inquiries if you would allow me. What about Bell's reflex? What about up-gaze saccade? What about active force generation test for the superior rectus? Because with good superior rectus function, I would go for inferior rectus recession with superior rectus resection in such large angles, while with poor superior rectus function, I would go for inferior rectus recession with transposition. And why spaced surgery in such a large angle? What about post-operative torsion, limitation in down gaze, and how are you going to treat? Lower lid retraction, and how are you going to treat? Finally, I would like to thank Dr. Mustafa for sharing with us such an interesting case with a smart, non-conventional management. Thank you, and Ramadan Kareem.
Hi, this is Faruk Orge, and first of all, Ramadan Mubarak to all my colleagues, and I would like to thank Dr. Mustafa Azab for allowing me to comment on this case, and fantastic case of a 21-year-old who had a significant right hypotropia and an exotropia. And at age 4, there was a history of trauma, and rightfully so. They've explored that with no history to rule out any orbital pathology with a CT scan, which came out normal. In the surgery, as they were planning the appropriate surgery, he had mentioned that the right forced duction test of the inferior rectus was mildly positive, which is interesting as there is he describes it as a -4 deficit. So it has to be either a restriction of some sort or a maybe elevation deficit caused by a different pathology, including double elevator palsies, again, injury to the superior rectus, which was perfectly normal. If it was mild, then one may wonder if she actually indeed have a monocular elevation palsy or a double elevator palsy. They have done successfully a R&R procedure for the big exotropia and recessed the inferior rectus. I'm sure they have dissected the lower retractors to avoid any lid malposition after the surgery, but despite the best efforts, obviously it still may happen, and we're seeing some of that effect as well. Well, she ended up really still having a significant amount of right hypotropia. This again could be simply because of a monocular elevation palsy or double elevator palsy, and if the inferior rectus is not really tight, a transposition of these muscles tend to be more successful. I really was curious about what the torsional measurements were preoperatively and in the first post-op, as well as I was curious about how the forceductions were after you had disinserted the inferior rectus. This could sometimes help with the further diagnosis. If it's to do with the inferior rectus, that may persist still, even if you place the muscle at 7 millimeters away from the original insertion. The next surgery was performed because of the increased or persistent hypotropia, more so seen in the adduction. And again, one can visit the other eye and go to the vertical recti, since the problem is more in the left gaze, or in oblique, or again transposition, as initially we thought about. That the problem with this could have been that doing only one horizontal rectus transposition, especially lateral rectus, may affect the exotropia, but beautiful outcome. One cannot deny the outcome, and so beautifully done. Thank you for the great presentation, and greetings to all my friends and colleagues.
Greetings, dear professors and colleagues, and welcome to ePost Ramadan episodes. I'm Heba Fouad, an assistant professor at Cairo University, and I will be presenting this interesting case. An 11-year-old child presented with diplopia and abnormal eye movement for 8 days. His medical and family history were negative, and he was not complaining of anything else, with no history of current or past illness. Ophthalmological examination showed manifest refraction of -2 sphere in the right eye with -1.75 astigmatism and -3.25 sphere with -1 astigmatism in the left eye. Best corrected visual acuity was 6.6 in both eyes. Fundus examination in both eyes was normal. He was orthotropic in primary position, but he had diplopia in side gazes, and that was confirmed by the Worth-4 dot test. This is a video showing ocular motility examination. He had bilateral limited adduction in both eyes and bilateral abduction nystagmus. He also showed a vertical pendular nystagmus on upgaze, and he was ortho in primary position. MRI brain and cervical spine was normal. Also MRA brain was normal. VEP showed bilateral delayed response. So what is your diagnosis? What is the site of the lesion, and what are the possible causes? Looking forward to your valuable comments. Thank you.